Hi, my name is Chris, and today I'm going to be talking about another OB landmark trial. This one happens to be called the Prom Trial, and it focuses on what is the preferred way to manage patients who break their bag of water at term. There had been not good evidence so far, and there was questions as whether you should induce the patients or expectantly manage them. The trial is a prospective, multi-centered study. It had an N of over 5,000 patients, and it broke the patients up into 4 different categories: an induction and expectant management category, and it compared their outcomes, both maternal and neonatal. So we have our induction category over here, and we have our expectant management category. And they broke up into 4 different areas. So there was 2 induction methods, and the 2 ways that they were going to do it was either oxytocin or prostaglandin E2, which is cervidil. For the expectant management, they were going to let them wait up to 4 days, and if not, then they were going to put them into 2 categories, oxytocin and E2. And then furthermore, in the prostaglandin category, if they had 2 episodes after 6 hours where there was not change, then they went back into the oxytocin category. Since oxytocin would be the gold standard, that was the overall pathway that they did. So looking at the outcomes for the paper from a maternal aspect, they were pretty much equal. The only exception that they did note was that there was reduced clinical chorioamnionitis in the induction with oxytocin group, small but noted. And what they were able to show was that there was less clinical chorioamnionitis. But the way the paper defined it, and that's important, was that if there was a fever of 37.5 Celsius with an additional finding of either leukocytosis in the amniotic fluid, or if they had foul-smelling discharge. And so that was their definition. And that's different than what ACOG recommends right now, which is suspected maternal fever, either 39 times 1 or 38 at least 30 minutes apart, in the setting of either maternal leukocytosis, fetal tachycardia, or foul-smelling cervical discharge. So it's a little bit different criteria. They'd be more strict now with how they defined a fever, but this was more of a broader definition of what a fever was. But in general, really, it was only that they had reduced in this. When they compared all of the groups, they did not notice that there was an increased rate of C-section, which suggests that if you want to do an induction, then that is a perfectly reasonable approach, and it's not going to increase the likelihood that you're going to have a C-section. When I looked at the induction categories between oxytocin and E2, they had comparable outcomes as well, but the E2 category had more cervical checks, so SVEs were increased in this group, even though it didn't lead to more chorioamnionitis. In addition to the maternal outcomes, there was also fetal outcomes and neonatal outcomes that were looked at as well. The main ones as well, when we're looking at the induction with oxytocin group, and this was on table 6, but what they were showing in this group was that there was less use of antibiotics in babies in this group, the induction with oxytocin, and they had shorter NICU stays. So if they had to go and stay in the neonatal intensive ICU, they were less likely to stay longer than 24 hours. But aside from that, there were really no other differences that they noted, kind of making both non-inferior choices when you want to decide. The last thing I want to talk about was, since this was a 1996 paper, there had been another paper that came out as well, and this was an Australian paper, and it was by Middleton et al., and it was in 2017. It reviewed 23 articles in total, and once again, its findings similarly replicated the Prom Trial, but it did show that there was a decreased risk for maternal infection, either whether you want to call that III or endometritis. And it was reduced in the induction group. There was also decreased risk of neonatal sepsis or probable sepsis within the induction group as well. And then once again, it repeated that there was no difference in C-section rates, neonatal mortality, or maternal morbidity or mortality. They did not comment further forward, they did not comment on breastfeeding, depression, meningitis, neck, and postpartum hemorrhage in those groups, so that hasn't been looked at. But all in all, the final final stance on this paper was that it is reasonable to induce patients with oxytocin, and in doing so, you might actually lower the risk for III. But it can be reasonable if patients want to be expectantly managed for a short time frame, maybe 12 to 16 hours. Thanks for tuning in.